Yes, it's a great evening, wonderful opportunity to meet all of you again. Wishing everyone a good evening, and this webinar session is exclusively targeted to people who are function testing, monitoring their functions, their actions. We think of function of the action. What we need in anatomy is a structural action. Means if a muscle has an origin and an insertion, we always see that the insertion moving toward origin as a concentric connection, or if the insertion is fixed, the origin is moving towards the insertion. You might see that in closed kinetic chain, okay, that is in weight bearing, whereas the open kinetic chain, where the muscle is contracting when there is no weight bearing or the distal segment is free to move. Pardon me if I am confusing you in the beginning, because when we approach knowledge from different sources, as a clinician and also as a therapist who is practicing, or we may be teaching academicians, there's a lot of conflicting information from various sources. So which essentially gives muscles like you can stretch the muscles, you can strengthen the muscles. Now of late the manual therapy has evolved into releasing the muscles. But all of them, most of the times you see that the strengthening is given in a manner where the patient never feels that I have to do this strengthening, because it is not relating to their daily activities or the functions. So you see that we try to convince, we try to explain the patients, we tell them a lot of evidence. Okay, sometimes we'll tell something like, or we might threaten the patient that if you don't do the exercise it will worsen. But still the patient do not do the exercises because we are not targeting the functional aspects. So this myofunctional testing course that's coming up this Sunday at Pondicherry, it's a unique course. The first and foremost, we are targeting muscle isolation. You'll see that individual muscle to be isolated from its partners, okay, or from its, I can say, enemies, okay, the antagonist. Partners could be the synergist for every muscle. Without going too much into the general introduction part or the principles of myofunctional testing, which is actually the course content, okay, the Sunday 9 to 6 we have a full one day dedicated to all the muscles, of course the most important muscles, to clear the controversy behind what is a structural perspective of muscle action versus a functional perspective of muscle performance. An action is different from a performance. Okay? For example, today's topic, I thought that we should keep the latissimus dorsi. As L for latissimus dorsi, you see the largest muscle in the human body. Although it might be the quadriceps, longest muscle could be the sartorius, okay? But if you see quadriceps, it's a combination of 4 muscles. So you can't tell that 4 muscles are joined and then it is largest. Individually if you see, latissimus dorsi will always get its ranking top. Another thing that is unique about this latissimus dorsi is, of course, the origin is from the thoracolumbar fascia. So that's from lower thorax, lumbar, and also a bit on the sacrum. The first, I can say, among the muscles of upper limb or the lower limb, the muscle which takes a facial origin is latissimus dorsi. The second uniqueness about the latissimus dorsi, of course, there are 5 factors which makes the latissimus dorsi unique. The first one is the fascia origin, the thoracolumbar fascia, of course. The posterior layer of the thoracolumbar fascia actually is the origin of latissimus dorsi. Second, it originates from the lumbar region, pelvis region. It connects that to the upper limb, and it's the only muscle that connects these 2 segments. So nowadays we are evolving like in a shoulder problem or a lateral epicondylalgia, patients should have a good core muscles. Okay, core muscle endurance or stability or strength is an important factor in upper limb rehabilitation. We must also understand that the force transmission directly from the pelvis or the lumbar spine is actually done only by the latissimus dorsi, direct one. So that's a very special feature. The third feature, of course, it's about our ancestral origin, what we say as phylogenetic. That means our apes, chimpanzees, before the human beings, okay, the evolution. The latissimus dorsi is the one which were helping our ancestors to hang on the trees, to climb from tree to tree, okay. And this muscle is also called as the climbing muscle. Now because of the sports, it's also called as the swimming muscle, because we are propelling our body using our upper extremity. So all the actions which involve that we are generating the force from upper limb and we are shifting the body. It could be a push-up, right? Or it could be a pull-ups, okay? Or it could be just hanging. Everything is about the latissimus dorsi. The fourth factor, of course, the latissimus dorsi is having multiple attachments. It's not just one segment. It's not just only from thoracolumbar fascia and then it goes. Okay? And you can see that even from scapula, the origin is there of the latissimus dorsi, the inferior angle. So almost like you can say teres major, then minor, and then the latissimus dorsi. Okay? In addition to the thoracolumbar fascia. So that means it can influence, it can, I can say, influence the interaction between scapula and the pelvis, pelvis and the lumbar spine and the scapula, and all of them, lumbar or pelvis, to even the arm or the shoulder. Anteriorly, of course, the latissimus dorsi is deeper to this anterior deltoid and the pectoralis major, but pectoralis major is inserted into the lateral lip of the bicipital groove, whereas teres major is attached to the medial lip of the bicipital groove, and on the floor of the bicipital groove is the insertion of latissimus dorsi. We popularly call this as the lady, because L, latissimus, okay, lady between 2 majors, because that major which is the pectoralis major laterally and the teres major which is medially, and latissimus dorsi. So that means it comes all the way and comes to the anterior aspect. So if you see this posterior axillary fold, okay, all the way, the fibers converging, twisting, and then getting into the anterior side of the arm, and inserted into the floor of the bicipital groove. Origin also and insertion also. Latissimus dorsi is anatomically having proximity or very close relationship to multiple structures. You can see thoracolumbar fascia, the posterior layer is latissimus dorsi, but the middle raphe gives the origin to the transversus abdominis. Transversus abdominis is very important for the core muscle, the pelvic control and the stability, lumbar stability. It's a global stabilizer of the lumbar spine, the transversus abdominis. So that means it could act as a relay whenever the spinal posture get changed, how that can influence the arm function. So I can rotate my trunk or I can laterally flex my trunk and then see that how a latissimus dorsi, okay, the action of latissimus dorsi, of course, it's a big three-dimensional action. If you want to take the arm all the way from the top, where you are elevating, externally rotating, and from that position you are taking it into an extension, adduction and a medial rotation of the arm. So similar to, of course, the one which we do like a swimming action, but from the top. The fifth factor in the latissimus dorsi is the relationship with the gluteus maximus of the lower limb. You can see that one side latissimus dorsi, for example this is the right side for this model, and the left side gluteus maximus, they form a diagonal force increasing the tension of the thoracolumbar fascia. When one diagonal is increased, the other diagonal will be relaxed. If you are increasing all four diagonals, yes, of course, thoracolumbar fascia, the tensile forces will be maximum. But functionally, if you see, during walking, we have lower limb movement. If it is the left lower limb forward, we have the right upper limb forward, the reciprocal arm swing, okay, accompanied with the rotation of the pelvis. Although it's not a huge effort that we push off with our arm, we recognize this during gait training in paraplegics, that we can use the latissimus dorsi and create a forward progression of the paralyzed leg where the gluteus maximus is not at all active, but still you can use this latissimus dorsi to get the limb progression forwards. So it's a very I can say, if you are using the mechanical properties of latissimus dorsi, you can understand the patient's body much better. So as you are looking at this muscle, you can decode its functions in different aspects. One is the neural innervation, the thoracodorsal nerve supplying the latissimus dorsi, and the second one is, I was telling you about the other structures in proximity. So you have all these trunk muscles which are in deeper layers, all are attached to thoracolumbar fascia. Thoracolumbar fascia is attached to multiple structures, right from quadratus lumborum to the transverse abdominis to, of course, the gluteus maximus. Even the opposite side latissimus dorsi is attached to the thoracolumbar fascia. Thoracolumbar fascia is a diamond shaped structure, okay, here. So both are attached to the thoracolumbar fascia, both the sides, latissimus dorsi. This is the reason you can see that when you elevate both the arms, okay, it will create a lordosis. If I would say latissimus dorsi is tightened or shortened, but some of the literature inappropriately says as thoracolumbar fascia tightness. Even our esteemed David Maggie, the orthopedic physical assessment textbook, provides a special test called as thoracolumbar fascia tightness test. That test is actually a latissimus dorsi tightness test. So thoracolumbar fascia can never become tight. In fact, not only this, any fascia in the body can never become tight. Fascia can undergo only distortion. And those distortions are explained by an osteopath called as Stephen Tipaldos. And they have developed a model called as the fascia distortion model, where they are explaining different types of fascia distortions, which will restrict the mobility of the fascia. But don't think that it is a tightness of the fascia. Never. AOMPT, we have adapted that fascia distortion model into a functional model called as fascia dysfunction model. And not only that, one muscle can influence another muscle wherever the other muscle is in the body. So latissimus dorsi, especially if it is crossing all the way from multiple segments, if you want to count, we are all telling two joint muscle, okay, multiple joint muscles, okay, we are telling in different segments, especially like the long finger flexors or the extensors. You can tell as they are crossing the elbow, they are crossing the wrist, then metacarpophalangeal, then proximal interphalangeal, distal interphalangeal, multiple joints they are all crossing. Extensor digitorum, for example. But whereas I specify more into elbow means humero-ulnar, humero-radial, superior radioulnar, then middle radioulnar, then distal radioulnar, radiocarpal, ulnocarpal, midcarpal, intercarpal, carpometacarpal, intermetacarpal, and then metacarpophalangeal, interphalangeal joints. Understood? Never ignore any joints, because you are not treating muscle, you are treating the person, and you are finding the muscle in dysfunction. Okay? This muscle dysfunction you diagnose doesn't mean that you have diagnosed the patient. You have diagnosed an abnormality in that patient. So it is your role to actually clear whether there are any other structures that is abnormal. So in close association with this muscle, which are the other muscles, they need to be tested. And the same way, this muscle, which muscles it can influence. For example, latissimus dorsi being a medial rotator, okay, of the shoulder, if you are considering only shoulder, because you have to consider separately shoulder, scapula, lumbar, then you see even pelvic girdle, okay, or the whole chain of the body, what I tell as a myokinetic chain. Myokinetic chain, muscle to muscle forces, how the forces get transmitted across the multiple muscles. That is myokinetic chain. Myofascial chains are different from myokinetic chains. Myokinetic chains are depending on the muscle activity. Myofascial chains are depends on the fascial connections between multiple muscles. Most of the people are instructed, or they are doing the courses, they are taught of myofascial chains, but not of the myokinetic chains. That is the difference there. Okay? And as you are looking into the role in the shoulder, for example, as a medial rotator, latissimus dorsi medially rotates the arm, the shoulder, in 120 degrees of elevation. In this you do a medial rotation, that is latissimus dorsi. But if the same, if you do in a 90-degree abduction, it becomes anterior deltoid. If you do in a 90-degree flexion, it becomes the clavicular fibers of the pectoralis major. Okay. And if you do in the neutral adduction, it becomes the teres major. And at 60-degree abduction, bring it to scaption, and then you do a medial rotation, it becomes the subscapularis. So the same medial rotator, it is associated functionally with multiple muscles who are the other medial rotators. That means they are all synergies. As I was demonstrating now that this 120 degrees different position, this is muscle isolation. With respect to the medial rotation, how you can isolate them individually. That is what is important, because our frozen shoulder patients come, or impingement syndrome of the shoulder, or anterior instability of the shoulder. Ultimately, the medial rotators of the shoulder are either the culprit or the victim. Culprit means their dysfunction is the cause of the problem, which is mostly in impingement syndrome. Victim, either in the instability, where an anterior instability because of a posterior capsule tightness will cause the medial rotators to become weak and excessively lengthened. The cause is actually the posterior capsule. We don't say as weakness of the medial rotators being the cause. Weakness of medial rotator is actually a pathomechanical dysfunction that is coexisting. The etiology. It's not the one which is symptomatic. Medial rotators never become symptomatic. Symptomatic is the anterior capsule or the superior labrum, which has gone into a tear anterior to posterior. It's a slap lesion in an athlete, a throwing athlete. So don't think that the muscle will be tight and the muscle will be symptomatic. It will have trigger points. Okay, that is undergraduate education. But if you are seeing the clinical reality, muscle dysfunction is present irrespective of symptoms, and the interaction between the various dysfunctions either makes the subject asymptomatic, so no problem at all are dysfunctional but no problem, homeostatically balanced, or multiple dysfunctions, patients comes with symptoms. So it is our role to identify which is the primary dysfunction. That primary dysfunction is either structurally interdependent because of the anatomical closeness. If latissimus dorsi structural interdependence, then it should come to transverse abdominis, quadratus lumborum, understood? Or even the aorta spinae. That is structural interdependence because structures are close to each other anatomically. Functional interdependence is a latissimus dorsi, thoracolumbar fascia, where transmitting the force across to the lower limb, the diagonal force transmission. So whenever you have rotational activity or reciprocal arm swing, leg swing, alternating, definitely the latissimus dorsi functional role and its interdependence comes into play. And also because of the facial interconnections between thoracolumbar fascia and also the visceral, the kidneys, even the innervation, the segmental myotomes of the latissimus dorsi and the spinal cord segments for the kidney, quadratus lumborum shares maximum Psoas major also maximum. Transverse abdomen is also maximum with the kidney. Okay. But here not only anatomical proximity with the kidney, but functionally also the spinal cord segment responsible for kidney is the same which is innervating the latissimus dorsi. So because of that, a visceral manipulation to the kidney will have a huge effect on the latissimus dorsi, or you do a release or you activate a latissimus dorsi will have a huge influence on the renal functions. That is what we emphasize in our course called as the viscerosomatic manual therapy. Viscerosomatic manual therapy. The interaction between visceral and the somatic structures. That is also functional interdependence. And as I was talking to you about the multiple origins and also scapula, then on the humerus, the insertion, this involves multiple segments. You can see in lumbar there are facet joints. In the ribs there are costotransverse, costovertebral joints. Thorax also facet joints, of course. In the sacrum, sacroiliac, iliosacral, okay, and all these joints have regional interdependence. So one is in the upper limb, maybe in the shoulder, another is in the shoulder girdle, that is the scapula, another is of course the lower thorax, then the lumbar, then the sacral, lumbosacral, or the sacroiliac and iliosacral. Everywhere there is an interdependence because all are commonly sharing the latissimus dorsi. So how do you get this into a clinical reality? Okay, that means a patient with a back pain or patient with a sacroiliac pain develops a shoulder pain. You know that latissimus dorsi is crying out for your help. It is the one which is a major dysfunctional link in the system to transmit the dysfunction from the pelvis to the shoulder. Same happens if someone is doing an upper limb activity like a carpentry or a drilling machine, okay, with the upper limb, and develops a back pain, the reverse. Even a bike, you are driving a bike, riding a bike, driving a car, getting back pain, all will essentially be the reverse direction of dysfunction, that is from upper limb to the core. Again the latissimus dorsi, because there is no other tissue that transmits the force first hand directly like the latissimus dorsi. So anatomy, yes, but we should not stick with the structural actions. What are the structural actions of latissimus dorsi given in textbooks? Okay, it is a lateral flexor, one side action, unilateral action. It's a lateral flexor of the lumbar spine or the thoracolumbar spine. Also assists in hiking motion with the quadratus lumborum. Rotates the trunk also to opposite side. So that means it's the left latissimus, this is right latissimus dorsi. It will right laterally flex and left rotate, because the axis of rotation is posterior to the facet joint. Same like how upper trapezius is. Okay, the attachment is ligamentum nuchae. Understood? So it's posterior to the axis of rotation. So because of that, it will rotate to opposite side, upper trapezius. Whereas levator scapulae is having the axis of rotation in front of the facet joints. So because of that, it will rotate the neck to the same side. So levator scapulae rotates to same side, upper trapezius rotates to opposite side. Similarly here, latissimus dorsi rotates to opposite side. And think of latissimus dorsi and trapezius, they are the first layer muscles of the back. Okay, superficial most layers of the back muscle, means trapezius and latissimus dorsi and thoracolumbar fascia. Deeper only the erector spinae and all comes after trapezius. Okay. Then you have this middle layer of levator scapulae, rhomboids, serratus posterior, superior and inferior. Then you get the erector spinae, which is all different groups, like semispinalis, multifidus, rotatoris, iliocostalis, and of course don't forget the longissimus, all the levels. So what we have to do in a patient, just the history, yes, they had a back pain, now they are having shoulder pain, yes, of course. But whenever you are examining the strength, don't just examine the medial rotation of the arm. Think of scapula, the inferior angle, the origin is there. So latissimus dorsi is also depressor of the scapula. But it cannot be act between origin to origin. Here also its origin, here also its origin. This origin it can act only if this insertion is fixed. So that means my arm has to be fixed. Then my scapula can be depressed by latissimus dorsi. Don't think that you can fix your trunk and act at the scapula, because trunk is also origin, here also it is origin. To act the origin, you have to fix the insertion. If you want a trunk lateral flexion or you want a hiking motion of the pelvis, you have to fix the arm and then do the hiking action or resist the lateral flexion. So that means you need to know that what should be the arm position, that is 120 degrees elevation. And if you want to be in the outer range, externally rotate the arm. Because if you keep it in neutral, it will shorten the latissimus dorsi and it will make it insufficient that it cannot act at the origin. Because there is multiple origin, it's a broad origin. So you have to elongate at the insertion. Then only it will act effectively, isolated. Either at the iliac crest, the pelvic hiking, or the lateral flexion lumbar, or even sacral motion. We have sacral motion, okay, unilateral flexion extension, torsions which are usually the backward torsion, right on left, left on right. The forward torsions are the right on right and then left on left. All those who are listening all this, you might feel like it's too much to listen. Pardon me, knowledge is much more bigger than what you are just listening. That is why you need to have a strong, not just a course provider, a knowledge provider. Not just to train your hands, train your brains. Both sides of the brains. So it is called as brains. Okay. And if you see that if you want to palpate the latissimus dorsi, yes, latissimus dorsi also gets trigger points. Major area is between the scapula and the thoracolumbar fascia. That is the region where we palpate for the trigger points. So when you are testing the muscle also, when you are resisting at the arm, you give force to the scapula, understood? Or you give force to the pelvis, or you give force to the lumbar and the sacrum, or you actually rotate the body so that you can distinguish even the sacral fibers to lumbar fibers, to the iliac fibers, to the costal fibers, or to the scapular fibers of latissimus dorsi. Each muscle is important in itself, and I see many professionals. I teach interdisciplinary audience. where somebody said, we also read anatomy. We read anatomy for 2 years in our degree. I asked them, name 5 muscles, tell their actions. Okay, that's the only question that I asked. Or one muscle alone you tell action, which is concentric action, eccentric action, open kinetic action, closed kinetic action, and as I told now, the structural interdependence, the functional interdependence, and the regional interdependence. The three, I can say, the 3 angles of the triangle of pathomechanics. Because we approach pathomechanics through this, the structural, functional, and the regional interdependence. So we don't miss anything. If the same is about the trapezius, of course we need to speak about the trapezius in a separate session, because that is a very, very beautiful muscle. Okay, and hope this session evening here on latissimus dorsi today opened your eyes into a new path of glorifying knowledge. Not search for textbooks, search for information that will make your brain to work, because textbooks make your brain to sleep. You all will agree with me. Understood? And most importantly, if you are doing additional courses, seriously rethink from whom you have to learn. Okay? It's not a joke. You just keep spending money, keep collecting certificates. But after a point of time, your conscience, you will know that you are not able to analyze the body. You are not able to go beyond the content that is provided in the course. That means you have become a recipe clinician, a protocol clinician, not a patient-centered, problem-solving clinician who diagnoses the solution. So this course on Sunday, more I can say that your participants will enjoy, and definitely it is our responsibility to ensure that every session makes it count for a life transforming milestone for the physios. This is a physio specific course, the muscle testing, which is myofunctional testing and muscle specific isolation, and not just for exercise alone, but also even releases or muscle energy techniques in presence of dysfunction, because there are various muscle dysfunctions that are possible. One is a spasm, another is the tightness or shortening, another is lengthening, another is having a trigger point, another is either it is overactive or underactive. That overactive or underactive could be concentric or eccentric. We distinguish these muscle dysfunctions across specific headings. Mechanical dysfunction of the muscles, that means shortening muscle, lengthened muscle, that's all. A neurophysiological dysfunction of muscles, overactivity, underactivity. Okay? And a clinical dysfunction of the muscles, like rupture, tendinitis, or trigger points, okay, or even intramuscular tear, hemorrhages, everything, every condition of the muscle, like even muscular dystrophy. It could be myotonia, it could be fibromyalgia, connective tissue disorder. Okay, so everything, that clinical dysfunction of the muscles, the disorders. But if you also see concentric eccentric is a type of the muscle activity. So it is actually under neurophysiological, but it comes under functional, where open kinetic versus closed kinetic. Open kinetic is mostly concentric, whereas the closed kinetic is mostly eccentric. Open kinetic, where the distal segment is free to move, is, I can say that it is more of insertion moving towards the origin, whereas the closed kinetic, where you are hanging and lifting the body, it is the insertion that is fixed and the origin moves towards the insertion. So what are the functional demands? Treatment of a person who is involved in upper limb activities and getting shoulder pain, which is a open kinetic chain, should be different from the same latissimus dorsi trigger point, both of them, but the second person tells, I am a swimmer or I am doing pull-ups. It's a closed kinetic chain. When you distinguish between these two subsets of the population, you are really becoming a clinician rather than administering the techniques as a technicians. Putting latissimus dorsi, needling, put the needle. Anyone can put the needle. Anyone can put the cup. Anyone can take the ISTM and do massages. Anyone can apply the tape. But the fact here lies, the true professional who is a clinician will know which position I have to keep, how I should activate this muscle, whether it is concentrically should be activated or eccentrically should be activated, or what way I should influence, whether kinematically or kinetically, to individualize the therapy for this patient. So this evening I wanted to highlight these aspects with an example of latissimus dorsi. I want to continue this series further, but it depends upon your responses and your enrollments into our courses. If you are enrolling into our courses, I will do more free sessions like this. If people want to encourage genuine education and from India being a global leader, Academy of Orthopedic Manual Physical Therapists, the MYMPT, is next to none. And we always boast of the pure knowledge which makes our clinicians more empowered to be more creative and more than everything, a better human being to take care of another human being, be it patients or the population at large. So good luck to all of you, and Ritu ma'am can also join on screen to provide a summary. Devanshu, sir. Okay. Let's see who are able to join on the screen and of course provide what they understood from the session and also further questions or inputs. Yes. Devanshu sir. Right. Ujjwal Gupta unable to join. Right. Do we have any participants here on the screen? Ritu ma'am also I have given request. Sony, VKY, Palani. Okay, Ritu ma'am not able to join. Okay, it's fine. So we can close the session and saying bye bye from the myofunctional model. Of course, the muscles teaching model it is. The hero of the upcoming Sunday myofunctional testing course. Bye bye and enjoy your evening. Right.